So at the outset, I would like to thank the AIOC committee, Dr. Somchila. It's been a privilege to be part of this session, and we are running a little short of time, so I may go a little faster, and you may have to catch up a little faster. And so I'll be presenting on Demodex infestation, and it's much more common than we all think. Basically, what happens, it's a mite. We call it a mighty mite, and sometimes we just miss it and we do not want to. So this 24-year-old gentleman comes to the clinic and was being treated for VKC of like tendular keratoconjunctivitis since 5 to 6 years, off and on medications, sometimes diagnosed rosacea, not really clear, and vision in the one eye was 6/9 and the other 6/18. And this is the picture how the patient comes with this exacerbation. You can see the edge being a little active. This is the other eye with the 6/9 vision. So 1 year later, started again on the steroids and the standard treatment for conjunctivitis, and you see that it's coming to the center, affecting the vision now a little more. And if you look at the other eye, that again is extending up to the center part. The patient was then started on oral immunosuppressions, thinking that this is a more immunological process, and Boston's clear lenses prescribed, which improved the vision of the patients. After 10 months, again he had this exacerbation. The patient was already on treatment and on mild steroids also. And both the eyes, there was this exacerbation which used to come. This is another young patient who came to us with 1.5-year-old history, diagnosed as VKC. Dr. Sharon has very beautifully explained how to treat them and was on treatment. The patient was also treated for viral keratitis, TB MON2 negative, and started steroids, and for which he developed glaucoma as well. So very careful use of non-steroidals. And there was congestion which was there all around with a one lesion on the cornea. Again, a young patient who presented, treated for VKC, having this inferior area which was a little more, having a lot of vascularization there in both the eyes presented. So after 2 years of this presentation, you see that the one of the eyes, it had this vascularization with an infiltration which was extending up to the center. And there was this small lesion which could be seen. Again, this young patient who presented with the corneal lesion inferior, but with vascularization. So what are the commonalities in all these patients? They were all young patients with chronic presentation and multiple consultations and mixed diagnosis. So what are actually we dealing with? So when you go into the details, one thing sometimes we do forget is looking at the lids. So these are the lids of all these 4 patients when we really thought that we're not dealing with something like a chronic viral keratitis or a VKC, but something a little beyond that. This was another patient who had sudden diminution in left eye since 1 week. And there was no history of any contact lens use, and that inferior in the lesion was there. When the patient came to us, he had some sort of diagnosis been made outside of acanthamoeba keratitis on PHMB. There was history of LASIK, which was done 7 years back. The treating surgeon then saw this lesion, got a little panicked, and patient was on PHMB. We did the scrapings when the patient came to us. Did not show much, but we continued on PHMB, thinking that this was the thing which was coming up. But what happened, with the treatment, the patient seemed to be a little better, but when the patient came back 1 week later, looked like better with the treatment which was given, and the same treatment continued, but 10 days later, again there was increase in the redness and pain. So this case, if we summarize, this was a young male with post-LASIK with infective keratitis and history of treatment with acanthamoeba. We thought there was no growth because we thought maybe we were dealing with the PHMB toxicity. We spoke to the local doctor, did not find much of a conclusive evidence of acanthamoeba there. So we stopped PHMB. The patient started to become better as the doses were tapered, but again came back with this florid inflammation in both the eyes. The lids were again bad. So what were we dealing with in these patients? Blepharokeratoconjunctivitis with recurrent history and a chronic episodes. And this is what actually came out to be the result in all of them. It was this mite which was there. So if you look at it over here, it has some projections which are there. And it is very easy to diagnose. The patient was treated with ivermectin lid scrubs with tea tree oils. And that is what we were dealing with. And 4 months later, the patient did well and is now under follow-up with just the lid scrubs being followed. This is what actually we call it as a Demodex dance. And sorry. And this is the video of how the mites look under normal microscope. You don't need a very fancy equipment. You just need to take out the lashes on a slide, just put normal saline on a cover slip, and this is visible on a microscope. So what actually is this ocular demodicosis or blepharoconjunctivitis? This is a mite which is there, and with two species of follicularum and brevis, which is now seen. What you basically see very clearly is the cylindrical dandruff, and the rate of its direct involvement is pretty high in normal population as well. But the action, the mechanism where it really has some side effect or the bad effects on the cornea is basically a direct damage, which could be follicular distension and hyperplasia, or it acts as a vector for bacteria, maybe leading to superadded infections and giant cell reaction to specifically for Demodex brevis in the sebaceous glands, leading to the blockade and causing much more inflammatory effect on the eye. So it may manifest as lid margin inflammation, or a blepharokeratoconjunctivitis, or a keratoconjunctivitis with superficial vascularization, marginal infiltration, and flecton like there. So these are the varied presentations which you have seen in all the cases over here of where blepharokeratoconjunctivitis not responding. And usually what is common, they are young, healthy individuals, multiple episodes of red eye, treated as allergic conjunctivitis, and frequent predisposition of prescription of steroid eye drops. So there is, these are the red flags which should come up when you're not able to take care of this patient as you must have thought I should be. And this is what the lids look like. So if you look at very details on these lids, there is cylindrical dandruff which comes. Diagnosis is simple by direct microscopy, 2 lashes each half, each lid, and just label which eye and which lid you are putting, and put it on the cover slip, and just a saline on the edge. And the microbiologist can very easily diagnose the presence of Demodex. It can be there. Treatment is simple by 50% tea tree oil. Initially, when we were doing this, we had to get it and the tea tree oil from maybe the Body Shop or some other cosmetic place. But now, Oculeaf, by the name of Oculeaf, that's a commercially available preparation which is now used for Demodex management. Ivermectin helps 1 week apart, 200 micrograms per kg. It's a 12 milligram tablet which is there, and just cleaning is fine. But maintaining personal hygiene, discard use facial makeups, washing, bedding and pillow, and treatment of the spouse is something which is recommended when you are dealing with these demodicosis. I would just briefly touch upon that viral keratitis sometimes is said to have a preponderance for demodicosis, and this may lead to more recurrence. This is one of the studies which definitely tells us about the potential role in ocular demodicosis in patients with concomitant refractory herpetic keratitis, and this is something we are also at our institute working on and looking at very details of these studies. And sometimes you have these recurrences and also associated Demodex keratitis. This is our published series of 14 patients with history of chronic red eyes and corneal involvement, and they all were diagnosed as demodicosis and treated with tea tree oil and oral ivermectin. This is another paper from our institute. So I would just say that ocular demodicosis is an underdiagnosed condition and should be kept when we are dealing with chronic red eyes. So please, I mean, I find it very simple, but it is much more there than we are seeing, and we are just trying to take care of the symptomatic patient at that point, and it comes back. So unless you're taking care of the underlying pathology, it's bound to come back and sometimes may become blinding to the patient. So thank you so much. I would like to acknowledge our department, especially Dr. Mathur, Dr. Neha, Dr. Nikunj. I have borrowed some cases from them as well, and the lab services who have been the backbone for treating these patients. Thank you.